Good evening to you all. COVID-19 is causing unprecedented disruption to world health. In all countries, medical services are fast reaching breaking point due to staff shortages. Elective surgeries are cancelled and surgeons are reallocated to serve in medical and intensive care units. Through this webinar, we hope to provide the essential knowledge that will allow surgeons to act in the very best interests of their patients. I'm pleased to welcome Gregor McNeill, Consultant in Intensive Care at the Royal Infirmary of Edinburgh, to take you through what we consider to be current optimal practice. Gregor.
Thank you, Alistair, for that introduction. It's a great honour for me to speak to you all tonight about this, as previously described, a very grave situation. And I'd like to take you through a bit about COVID and also, most crucially, our response. And the key thing about our response is that we need your help. And we need to help each other in which is quite clearly the greatest health emergency we've ever seen in modern times. What am I basing this talk on? Well, you've heard my role in the NHS here in Edinburgh. I'm a full-time intensivist, and I also have a background in acute medicine. And that's why I think I can give you some insight in terms of what your role may be. I can give you some insights into the local planning we here in Edinburgh have been doing over the past couple of weeks. And certainly it is a very fast-moving situation. There are some things I've got down in my slides, but I also hope to give you an insight in terms of where we are here today in Edinburgh and what we can expect in the coming days and weeks. I link in with other clinical leads across the UK through a Faculty of Intensive Care Medicine group that incorporates all clinical leads from every unit across the UK. So I hope to also give you some insight about what you may be experiencing in your local area, whether it is in the UK, overseas. And certainly there are national challenges, but there are also local challenges that will be local to you. I can also give you some observations about my clinical experience of these patients. I was on call for our ICU over last week and I've been in a managerial role this week. But certainly I have an experience of managing our first 6 cases here in Edinburgh. And we're now up to 8 cases here in the Royal Infirmary in our ICU. As we all know, COVID-19 is with us. You will have already felt the effect. It's highly likely, certainly if you're in the UK, that your elective non-cancer lists have already been cancelled. As Alistair has mentioned, you will be tasked with managing these patients in some regard. And they're sick, and they get very sick, and sometimes they get very sick very quickly. And we can talk as we go through the presentation about how you will come across these patients. Maybe only last week, you were maybe envisaging a time where you would be working alongside the physicians managing these patients in cohort wards. And that is true. But it's also important to say to you, and if you're working clinically in the UK right now, you'll always be noting this, these patients are popping up here, there, and everywhere. Your patient who has come in with a ruptured appendix may be COVID positive. And it may be picked up when your patient goes through the CT scanner that your radiologist will pick up. They have the classical CT appearance. And it may be picked up from your elective cases when they're sitting on the surgical ward post-operatively and they spike a temperature. Because unfortunately, COVID-19 is spreading very rapidly, and it is everywhere in your healthcare facility, and it's going to grow. We do know something about how to manage these patients. And as we go through to tonight's talk, in the time I've had available when not clinical, I hope to give you some very basic pointers about what to look out for. So you can manage these patients optimally wherever you are tasked to do that. We're going to go through the diagnostics. We'll also go through some of the investigations, and also a kind of a treatment algorithm. As we go through the diagnostics, investigation, and treatment algorithm, I hope to reflect our experience here locally in Edinburgh, but also the experience in different healthcare systems, how diagnostics investigations were managed when the cases first cropped up in China, and how they've done things in Italy. And there's subtle differences. I'll probably leave you with what we're doing locally here in the NHS in the UK. We'll talk about the care of the COVID-19 patient. We will talk about organisation of care and how your hospital, how my hospital is organising care to try and cope with this massive influx of patients with acute hypoxic respiratory failure. We'll touch on the settings of the admission ward, the general ward, and we'll end with how these patients are managed in the ICU. And I am very conscious that many of you as practicing surgeons will have spent time in your training, maybe in ICU, maybe many years ago, but you have some of these skills that you need to manage these patients, even in the ICU setting. Right at the end, we'll talk about some novel therapies. I'm certainly not an expert on this, but other colleagues in my department are, and certainly work by colleagues such as Kenneth Bailey here in Edinburgh, who are rapidly trying to develop research programs so we can study this disease and come up with some novel therapies. And I'm going to end, I think rightly so, on infection control, because the most important thing, one of the most important things that happens in this whole pandemic is that you as a healthcare provider protect yourself as much as possible. And as these cases are coming in large number rapidly, we have to maintain our own personal protective equipment. And that is absolutely key. And that's what I'll be ending the talk on. So the virus itself, there is a pretty picture of the virus. It looks like a nice cuddly toy, but it's certainly not. We have seen coronaviruses before. You will remember some years ago in Asia, the SARS outbreak is often termed the pandemic that did not happen. There was a further outbreak of severe respiratory failure due to coronavirus some years ago, focused in Saudi Arabia with the MERS-CoV outbreak. Both these outbreaks were centered around patients developing acute hypoxic respiratory failure requiring invasive ventilation. Both had a high mortality rate. It is important to say that although this COVID-19 outbreak is also coronavirus, the clinical presentation and clinical course is different. And again, there are certain aspects of COVID-19 that we know from both the large data sets now in China and also the Italian experience that are important to highlight. Transmission. And again, there are things that we do not know. I would point you to the web link at the bottom of this slide. There is an excellent summary of the aspects of COVID-19 in the BMJ best practice document that was published last week. A health warning for all educational material around COVID-19, including my slides actually, is that this is a very fast developing situation. And certainly if I had given this talk to you this time last week, some of the data in my slides would be different. But certainly what I'm telling you right now is what I know to be true and up to date at this time. Transmission, this, and particularly compared to our previous coronavirus issues, COVID-19 is very transmissible, primarily through droplet spread, saliva. What does that mean for us as healthcare workers? You've all heard the advice in terms of hand washing and distance measures, but it is very transmissible. And certainly what we're seeing here at Edinburgh is if a patient in an open ward comes up as positive, it's highly likely that the patients in the bed space next to them will be positive in the number. Things that we are unsure about, fecal transmission, breastfeeding, vaginal delivery, we are unsure at this present time. And again, you may have heard in the wider media about clinical presentation. And it is true, many of the patients that we have seen here at Edinburgh and reported in the wider literature present with a high fever, a dry cough and shortness of breath. What I would also say to you, though, that particularly for those of you who continue to work within the surgical field, they will present in other ways. And your patients may have a surgical condition and also be COVID positive. And we are already seeing that here in Edinburgh. Certainly last week, we were doing a lot of testing in patients who we thought highly likely to have just a simple post-operative chest infection. But actually, when we test them, they are COVID positive. The main presenting organ issue, though, is focused around respiratory failure. The data we have from both China and Italy suggests that the next most likely organ failure group is that around cardiac instability. They can present with malignant tachyarrhythmias. So in our experience, with our limited experience here in Edinburgh, we've not seen that as yet, but it is well described from both the Chinese data and Italian data. Systemic shock, though, is less of a feature. And I'll talk about that more when we get to the presentation to critical care session part of my slides. And again, I stress that it is a fast-moving situation. On the left of this panel here, it is true that our experience here in Edinburgh is similar to experience in Italy and China. The vast majority of patients, and we're talking 80 to 90%, are male. It gives me no pleasure to say that. They are also elderly, and they do have comorbidities. All of this data, though, is very much influenced by the testing policy of the locale you're in, and that's why all these kind of pointers in terms of how the patients will present have to be taken with a pinch of salt. The National ICU Audit report in England, ICNAR, published their early data of the UK experience on Sunday. And that showed that there were a significant number of patients who were presenting certainly to critical care who were younger and had very limited comorbidities. Here there is a wider pool of comorbid patients who have COVID-19 does affect. But from my point of view, as an intensive care physician, I'm expecting patients in my ICU, and have patients in my ICU who are middle-aged, varying between their 40s and their 60s, and are fully functioning members of society with low frailty. They may have hypertension, they may have well-controlled diabetes, but they are not hugely comorbid. It is true that both from the Italian data set and also the Chinese data set, children do not appear to be affected severely. From the initial Italian data and Chinese data, there didn't seem to be large numbers of patients who were severely affected who were pregnant. And that is in marked contrast to other significant kind of viral ARDS situations we've seen in the past in critical care. If we think back to 2009, 2008, when we had our a large number of H1N1 viral cases, those patients, many of those, the most severely affected patients were pregnant women. And we didn't think that was the case here in COVID-19. A health warning on that, and the reason I've got a question mark there, is our early ICNAR data in the UK of the 200 patients described requiring critical care, 2 were pregnant women. So I think the other health warning is that the epidemiology and the disease picture that we've seen in China is subtly different when it comes to the Italian model. And again, we may be seeing something subtly different in our UK model. And again, in terms of percentages and things, it's difficult to give you a clear picture because of the limited amount of testing we have in the community at this time here in the UK. And again, if you go to the wider medical literature and also the wider general media, you will see this debate about whether you should be doing high volume testing in the community, low volume targeted testing. For us as clinicians on the front line, you really have to assess the patients on a case-by-case basis. And again, when we get into the nitty-gritty of the clinical presentation, I'll give you pointers on what to look out for. And again, here, I wrote these slides before the weekend, and certainly before the UK lockdown, what we were seeing in the previous 2 weeks, our initial part of the infected period within the UK, we were seeing patients who were becoming slowly hypoxic. They would become symptomatic at home. They usually had a travel history that they'd been to an at-risk area, and they would be picked up by a local infectious diseases team. They'd go to the infectious diseases ward, and they would slowly become hypoxic over the next 5 days. The thing here to really pick up is that although there is rightly a lot of panic about the situation, the actual disease process here, it's slow. It becomes slowly hypoxic. And certainly in the first numbers of patients that we escalated to invasive ventilation here in Edinburgh, we had a lot of time to watch these patients as they became slowly hypoxic on the general ward. As I alluded to before, our colleagues in Italy have reported high degree of cardiovascular instability also being present at presentation. We have not seen that yet here, but it's likely we haven't seen the disease volume yet. The presentation, however, really over the past 3 days has changed. And again, that's not a change in the disease pathology, that's a change in how society is currently working. The cases that we have seen in the past 3 days have presented to our emergency department late and grossly hypoxic. And what we have seen since our limitation of travel and now our lockdown in the past 24 hours in the UK is that, and this goes actually beyond COVID-19, patients are presenting to hospital, whatever their emergency, very, very late. Whether that is generalized sepsis, but it's also certainly true of COVID-19. And we are finding patients who may have been slowly becoming hypoxic at home and then have presented late to hospital and are coming into our emergency room with saturations of 60, 70%. And in that situation, clearly, we have to act very fast to intubate them at scene and transfer them to the ICU. And again, aspects around intubation, which may have been of interest to you, I will go into more detail as we go through the talk. So you can see on this panel, there's a number of investigations up there. Some of them will be standard in your local institution, some of them may not be. The thing I really want to highlight is some of the diagnostically key bits and pieces, but also prognostically as well. Diagnostically, leukopenia is the one thing, if you've got a good history, you've got symptoms, you look at their blood profile and they've got leukopenia, in this current climate, it's highly likely they could well be positive for COVID-19. In terms of prognostic information, and again, we are now doing these panel tests really as a reasonably standard data set when they come into ICU. There's some evidence that a raised LDH and certainly a raised D-dimer, maybe also a raised ferritin, may be prognostically useful. And again, that is mentioned in the BMJ summary document that came out last week. We don't know the role of it, but certainly we're gathering that data on all our patients. It may be very useful to our colleagues in research as they try and model who is at most risk of deterioration. You may also see a raised troponin if there's myocardial involvement. You should, as many of these patients will present with features that could be characterized as possible sepsis, do blood culture and sputum culture. But it's important to emphasize that at present the data suggests these patients are not coming with a high rate of secondary bacterial infection. And even when they're intubated in ICU so far, we're not seeing huge issues of secondary bacterial infection at present. In terms of the further investigations you should be thinking about, one of the things, and I'll go into a bit more detail about this, is the kind of the nasal and mouth swab testing, which is generally done through a kind of a PCR testing model. We have to be quite careful about that because it's slightly dependent on the quality of the sample you get, and there is a high false negative rate. And certainly, if you have a patient either on the surgical ward, as on your surgical take, who could have some of the symptoms consistent with COVID-19, or you're working in a medical ward assisting a physician, if the story is good, they have leukopenia and they have a negative throat swab, but they continue to deteriorate, and they've got the other bits and bobs that I'm about to go through, you should be highly concerned that the patient does have COVID-19. Your local infectious diseases department will advise you on this, and there will be local policies on this. But certainly, even in Edinburgh right now, with a very limited experience of kind of 10 days, we've seen a large number of patients come through who are nasal and mouth swab, sometimes repeatedly negative. When they end up on a ventilator, we do a deep endotracheal aspirate sample, then they come up as positive. In terms of the chest x-ray, we're really talking about acute respiratory distress syndrome. So we're talking about bilateral lung infiltrates in the majority of cases. It is interesting, and we'll go through some panels looking at CT findings shortly, but CT, although it's not recommended by our own College of Radiologists here in the UK as a kind of a great diagnostic use, has been used internationally, particularly in areas where they found it difficult to access PCR testing. And certainly colleagues in China imaged patients on the way up to ICU, and they developed a really reasonably clear idea of what the CT changes were. And certainly for you as a practicing surgeon, you may already be familiar with this. You may be putting through a patient through a scanner for some different reason, some suspected abdominal pathology, and you may suddenly find that your radiologist is calling you up because there are characteristic features on the CT chest imaging that they have. So in terms of the PCR test, this is varying lab to lab, but it's essentially based on single-stranded RNA, and that is amplified by PCR to get DNA. Again, though, I have to emphasize that it is not a completely reliable test. And if you have a good history and the patient has deteriorating respiratory function, even if you have a negative nasal swab, you need to be suspicious. And this aspect is an additional challenge to healthcare planners, in that you may need to think about where your patients go. Do you have a COVID ward? Do you have a possible COVID ward? Do you have a confirmed COVID ward? And again, even if you continue to practice in general surgery, how do you cohort your patients who are COVID positive or possible within your surgical take? There's lots of challenges there. It is possible to detect serum antibodies further down the line, but again, at the sharp end, when the patient is admitted, that we are not routinely doing these tests here in Edinburgh, and that may be of less use to you. Again, in terms of prognostication, D-dimer is useful. Most of the patients we've seen as a mildly raised CRP, we don't routinely do procalcitonin here in Edinburgh, but it is often normal. A markedly raised CRP, you might want to think about something else going on, such as secondary infection. If, and again, we're seeing this here in Edinburgh, if the D-dimer is markedly raised, that may be suggestive of poor prognosis. And again, there may be other things there. We've mentioned the low lymphocyte count, a low platelet count again. or a kind of a DIC picture on your bloods may be associated with a poor outcome. And these CT panel pictures are taken from colleagues in Italy, and you can see the widespread basal changes on the lung. This pattern of acute respiratory distress syndrome is described as a crazy paving pattern at the base of the lungs, and is characteristic of COVID-19. And again, the distribution, the patchy distribution of these changes can be well seen in this series of CT panels. And the chest X-ray will look like this. And the key thing is, you may look at that chest and think, my goodness, there's a lot of changes there. But often the patients at this stage, they may be very unwell. You can see this patient's intubated, but they may be relatively well from the end of the bed. And it is well described, and we've seen this in our experience here in Edinburgh already. Patients may be grossly hypoxic, but their respiratory rate may not be that raised. And again, we need to factor that in terms of how we respond to these patients. Many of these patients will be at home and be perfectly well. But as we know, and the reason we're talking about this today, a proportion of the patients out there will come in and will require oxygen therapy. And a proportion of the patients, and in Italy we're talking about 5 to 10%, will require intensive care. And certainly I'm not an expert in modelling, but what we do know is that we are expecting to have to expand our ICUs rapidly to deal with that small percentage of patients that have severe acute respiratory failure. And what we are trying to model here in the UK is, are we following the same trajectory as Italy, or a slightly different trajectory? And you all know in the widespread media about how we are trying to flatten that curve so we as healthcare providers can cope with the amount of patients coming in. And we don't know if we're winning that battle at the moment or not here in the UK. What will your local hospital experience be? Well, it will vary from site to site. You can expect that your surgical wards will be turned into a COVID isolation ward. The first ward to become a COVID isolation ward here in the Royal Infirmary in Edinburgh was an elective orthopaedic ward. These wards will be staffed initially by physicians, but it is almost certain that you will have to work alongside them and be supported by them. Critical care areas will expand. Our own Scottish Government asked us to investigate last week doubling capacity, and if you've been watching the news today, you can see that we've been tasked to quadruple capacity, and we are looking into exactly how we do that and how we plan and where we go to make that happen. If you are a surgeon with critical care experience or recent critical care experience, it is quite possible also that you will be pulled into managing things in critical care. And even if you don't have critical care experience, your skills as a surgeon, and we can talk about this later, they may not be obvious to you, but we can use those in critical care in a number of ways. The ward management, and again, although the situation is scary, the disease is maybe not that scary, maybe not that interesting. There's not much to do. You need to give the patient something to lower their temperature, and the temperature can be very high, 39, 40. You need to give them oxygen, and you need to watch for deterioration. And one of the ways that we in the UK are trying to lead in terms of managing everything is to make sure that, and this is one thing you will have to focus on if you're working in this environment, is that there is early anticipatory care planning at the time of admission to hospital. So we have a very clear idea when patients become hypoxic, exactly what the patient may or may not benefit from. And you will all do anticipatory care planning in your usual acute surgical practice. You have a good grasp of what you can and cannot subject your patients to, particularly if they have significant comorbidities. This has very much been crystallised across the UK our own medical director, surgical colleague Tracy Gillis, is leading on that here in the Royal Infirmary of Edinburgh, certainly across our health area, to make sure we have a clear anticipatory care plan for all patients coming into our hospitals. And certainly that has already been a great benefit to us in Edinburgh, because we can really focus very early on the patients who need escalation, and we can escalate them rapidly to the care they need. But we can also, on the same token, provide good limited ward care to patients where that is appropriate. And we're also working as an ICU community closely with our palliative care colleagues to make sure that if patients are not going to benefit from critical care, that they get good symptomatic relief in a ward environment. And there are challenges around that because of the nature of COVID-19. So going into that anticipatory care planning in a bit more detail, there is a very clear and very useful guidance that was published by our colleagues down south, NICE, again over the weekend, looking at how we do anticipated care planning, particularly in the setting of COVID-19. It uses a clinical frailty scale that we're reasonably familiar with in the ICU community, and certainly it would be useful for you to kind of familiarize yourself with that. When you read it, you're really likely to reflect that it's what you already do in your usual clinical practice. It allows you it gives you a way that you can easily apply that to maybe a setting that may be less familiar to you. And it's clear once you make that judgment in the admission area that is clearly documented. And again, this is the clinical frailty score we're using, and where we're really the spots where we think patients are less likely, certainly in COVID-19, to benefit from that escalation in care is once patients start to get to that 0.5 in the scale, mildly frail. We know certainly these patients, when they get to that level of frailty, that severe ARDS, which is what COVID-19 causes, they may well be unlikely to benefit from the interventions we have available to us. As towards the end of the talk, we'll go through what those are, and they are limited. This schema from the NICE guidelines, you can see, and you can see really if the patient is less frail, the key is referring the patient relatively early to critical care. If they are more frail, then it should be considered that the care should be limited to a ward setting. What I would emphasise, and I'm sure my intensive care colleagues across the UK and wider would also emphasise, is that there will be cases where it is not clear. And in those borderline cases, certainly we in Edinburgh are very happy to be involved with the ward teams to discuss what is and is not possible. But if the patient does have low frailty and is likely to benefit from critical care, we want to hear about them early. Although the initial part of the disease can be quite indolent, gradually increasing oxygen requirement, these patients, once they get to a tipping point, can deteriorate rapidly. Because of the data that we have from China and Italy, we know that there isn't a very clear rule at all for non-invasive ventilation or high-flow oxygen therapy. There is an additional challenge because of the aerosolizing nature of these therapies. And certainly in common with the rest of the UK, we are in Edinburgh not using high-flow nasal oxygen therapy or non-invasive ventilation for any of our ICU escalated patients at present. As many of you will be aware, high-flow nasal oxygen therapy is a cornerstone of treating hypoxic respiratory failure for us, particularly in a surgical group, and to not have that available to us changes the situation quite a lot. What we have been practicing in Edinburgh, and there are other guidelines out there, is once the patient is requiring more than 60% oxygen, we really want to be getting that patient into critical care and considering where we go from there. If the respiratory rate is raised, it's easy. We would probably at that stage proceed to intubation. If it's not, that can be actually falsely reassuring. And again, a key thing to emphasize to you is that the news chart, which you may well be using if you practice in the UK, may be unreliable in this setting. We really want to focus on the respiratory parameters, and if you're hitting that 60%, we probably want to have a conversation about where we go next. And because of a good anticipated care planning, we should know that already. And if we do need to escalate these patients, we really want to do that in a timely manner. When the patients arrive in critical care, off the bat, we want to place an arterial line so we can invasively monitor them. And we really want to proceed to intubation if they continue to require that similar amount of oxygen therapy. Why are we so jumpy about intubating these patients early? It really is because they do, once they get to that level of hypoxia, once we intubate them, they desaturate rapidly. We, in Edinburgh, along with ICU colleagues across the UK and wider, have altered the way we do our rapid sequence inductions and intubations for these patients. One, to take account of this rapid desaturation. This is something we haven't really seen in previous viral pneumonias to this degree. And two, to minimize droplet spread. This link, I'm not going to open it right now, but as these slides are shared, you have the great pleasure of seeing me do a simulated intubation of a COVID patient here in the ICU in Edinburgh to show how we do that. How we do that, I'll take you through kind of the main principles of that. The key, and I'll come back to this at the end, whenever we do any intervention with our COVID-19 patients where it's an aerosol generating procedure, is PPE, PPE, PPE. And we really don't want any situation that's going to make us rush our donning and doffing of our PPE. So we want control. So we'll place our PPE before we enter the room. Before we enter the patient's room, we'll do our full checklist run through so we're all our kit ready to intubate these patients. Once we get in the room, we really want that first attempt, best attempt intubation. So many of us would reach straight off the bat or a video laryngoscope so we can get that tube in as quickly as possible. And that also may mean that we have to get less close to the patient as we tube them to do that safely in a controlled manner. I'm not going to go into the details in this forum, but we use tube clamps as well far more frequently in this situation when we swap the circuits over between our handbag circuit and ventilator, again, to minimize aerosolization and spread. And when we finish the procedure, again, we need to really focus with a buddy when we doff our PPE to prevent us from contaminating each other. And again, when you are treating these patients in a level 3 environment with your full PPE, particularly if it's a high stakes intervention, whatever it is, you really want that buddy to make sure when you take off your PPE that you're staying safe and you're not contaminating yourself. Once we've intubated these patients, this is a slide taken from colleagues in China. I have to confess, in Scotland, again, with a concern about aerosolization, we haven't been routinely bronchoscoping these patients. But certainly, this slide looks slightly out of focus. The main finding is a really kind of gross hyperemic swelling of the airways. And that really ties in with what we see, which is a really nasty hypoxic picture once these patients are put on the ventilator. And again, it's quite frustrating to treat because they do have a severe acute respiratory distress syndrome or widespread inflammation of the lungs, and they are hypoxic. But actually, their lungs are reasonably compliant. They're easy to ventilate, but they just take a long time to get better. And that's what we're seeing in common with the experience of our colleagues in Italy. These patients get stuck on the ventilator, not requiring critical levels of oxygen, really, but just enough that it makes it difficult for us to liberate them from that ventilator. When we manage these patients on the ventilator, we really want to manage them as per what we call standard lung protective ventilation. And what we're talking about then, you don't need to know the details of this, is we're trying to limit the pressure of the lungs, give the patient baby lung breaths so we prevent barrel trauma, but also volume trauma of the lungs. The baseline pressure, the PEEP that we're applying on the ventilator seems crucial. And these patients do tend to be PEEP responsive. If we recruit up the lungs and have that baseline pressure on the ventilator, recruiting up more lung units, and that does seem to be in COVID-19, the patients do respond to that. So we use a relatively high level of baseline pressure, a high level of PEEP. We watch out for cardiovascular instability. Again, in our caseload here in Royal in Edinburgh, we haven't seen that yet. It is well reported, including tachyarrhythmias in the wider literature. The key intervention appears to be, certainly from the Italian experience, is prone ventilation. Prone ventilation is well described in the management of ARDS. It allows us to access the posterior, often dormant lung units, and allows us to effectively treat severe ARDS on the ventilator. And even outside COVID, we have kind of very good numbers needed to treat for prone ventilation. We would do that if the patient is really stuck on more than 60% oxygen on the ventilator, and we would prone the patients for 16 hours. And certainly, I haven't told our colleagues in orthopedic surgery here in Edinburgh, but certainly we are looking about how we organise care to have proning teams, as they did in Italy, whereby we will be proning large numbers of these patients in series over a kind of a shift, so they can get the benefit from that intervention. And typically, we would prone a patient if they're on 60%. Prior to pruning, we would often see that drop to 40% once they're pruned. But the nature of COVID-19 is these patients take a long time to get anywhere. And we are looking at multiple pruning procedures for these patients. And certainly in our very limited group here in Edinburgh, that is what we found, that the majority of them do respond to pruning, but they need multiple pruning episodes. And whenever you prune a patient, you have to do it in a systematic manner with an airway person at the top end and 5 others to make sure all tubes stay in the right place. And certainly we are paranoid about disconnecting the ventilator, because that will obviously generate aerosolization. And so we do all this with full PPE on. Coming towards the end of the ICU part, there is interest in terms of extracorporeal support for these patients. And actually, we have a very well-developed network of 5, soon to be 6, UK ECMO centres, the 6 coming online in Aberdeen next month, where patients can be cohorted if they have the most severe respiratory failure. Again, if we look at the Italian data, there wasn't a lot of ECMO used. Often these patients were kind of stuck in that middle ground where they were responding to pruning, but not that hypoxic you would think about such an invasive procedure as ECMO. I have to tell you though, in common with the patients in the UK being slightly less comorbid and slightly younger, we do have a large number of patients already on ECMO in the UK. Certainly in the centres down south of England that have been hit hardest earlier in this pandemic. So that the guidance on that may be changing. But certainly if your patient is grossly hypoxic using standard referral criteria, ECMO may be an option. And that would be veno-veno ECMO, which is essentially kind of externally oxygenating the blood. In terms of a panel here, you can see on the left VA ECMO, where we support the failing heart. There are, beyond the 5/6 UK ECMO centres, there are other centres, such as the Royal Infirmary of Edinburgh, where we don't routinely manage severe respiratory failure. We do, however, use VA ECMO in our general and also cardiac ICU practice to wean patients off pump post-cardiac surgery, but also we use VA ECMO for post-cardiac arrest patients, severe overdoses, and severe cardiogenic shock. And it is yet to be seen whether centres such as ours who have expertise will be part of a national surge plan in the UK to support VV ECMO. We wait to hear about that. Certainly, as we speak, the VV ECMO network in the UK is functioning, and there are a number of patients with COVID-19 on ECMO. What are we doing for those patients? Well, essentially, the most simple way to do that is you take venous blood out of the femoral vein, you put that blood through a rotary pump and then an oxygenator, and you return that blood, which will be fully oxygenated with the oxygenator working well at about 30 kilopascals of oxygen, back into the right internal jugular vein. And that allows you to rest the lungs, allows the patient to recover their ARDS. You can slowly wean the patient off the ECMO circuit in due course. Clearly, this is the most invasive respiratory support we have, so we would only reserve it for patients who are really have a really low frailty or are previously kind of fit and well. And again, these patients don't do well if they're already in multiple organ failure. The most benefit is for people who have the most severe single organ respiratory failure. And in terms of the clinical course, well, again, we don't know, and we're too early into this in our UK modelling to work out what to do. And we do look towards our colleagues in Italy, and they have had great challenges in terms of successfully weaning patients off the ventilator in COVID-19. And part of that may be due to the difficulty in kind of resourcing their response to this pandemic. And we may find we're in a similar position. We are not clear yet in terms of role of tracheostomy. We suspect that may well be required given the severity of the ARDS and the length of time it's lasting, that these patients would not get off the ventilator in one go. We would have to bridge that wean off the ventilator with a tracheostomy. And again, one of the challenges we may find, because of the massive volume of patients we're expecting, is how do we get the teams together to perform that procedure to allow the patients to be liberated on the ventilator in due course. There may be great interest out there in terms of experimental therapies, and again, I'm slightly nervous talking about this because I have no particular expertise in this area. But what I can tell you is many ICUs that are very research active, such as one here at Edinburgh, are rapidly upscaling research projects to look at possible interventions. These may include antiviral therapies. They may include chloroquine has also been described, and other therapies. Many of those are targeted at what we know in terms of the ACE2 receptor that the virus may well bind to. So there has been some interest, again, in terms of angiotensin 2 antagonists, whether they may have a role. But as yet, we just don't know. There have been trials of antiviral therapies in China, which have shown some promise. But again, we in the UK are taking a national steer on what therapies will be used, and they're likely to be part of rapidly developed clinical trials. And again, we are interested in that association with the ACE2 receptor, and whether that may have allow us a target when treating this disease. And I'm going to finish, as I said I would, with infection control. And the key thing I'll say here is you must follow your local guidance and you have to place a degree of trust in your local health protection team or your infection control team. And you should know what your local guidance is. 2 weeks ago, we had 4 sets of guidance across the UK. We have very rapidly come together. It doesn't matter whether you're in Northern Ireland, Wales, or Scotland, or England. You have the same guidance, and you should be using the same standard of PPE. The challenges in terms of the supply line to get that PPE to you are well described in the media, and I'm not going to go into them now. But you should know how to don and how to doff. These are terms that we maybe were foreign to us a month ago, but I seem to reiterate it on an almost hourly basis in my current situation. These are guidance from documents in China, which is a similar approach. And again, there is variation, which you should know what your local practice is. In terms of basic principles, we in the UK have very much gone for a lighter, less kit approach when putting our PPE on. And one of the reasons, a pretty good reason for that, is the more complicated your PPE is, maybe the higher risk that you contaminate yourself as you're trying to take it off, as you're trying to doff. I'm going to finish with some slides that may be relevant to the operating theatre, and again, some guidance here about how we deal with spills or fluids. And essentially, the cornerstone of that is using chlorine-based products to clean areas. Again, I have no particular expertise in this area as a practicing physician, but how you clean your operating theatre will be dependent on your local policies, but it's very much the same, similar to how you would for an HIV patient, that you chlorine and disinfect all surfaces. Although this slide is about bodies, I think it's probably important to emphasize the holistic aspect. And one of the great challenges that we see in Italy, and we've sadly already seen it in the UK, is the challenges around end of life, and that maybe the families will not, they will not be able to visit their loved one in their last days, and that is a huge challenge to us in intensive care. How we dispose of the bodies thereafter is very much via standard practice. That will involve PPE. You can get further information from the combined ICM anesthesia website, which these organisations have come together to provide to you. As I draw to the end, slightly over time maybe, what I would really draw you to is two parts of this website. One is a bit on cross-working, where you, as a surgeon, what transferable skills do you have? That is laid out in that area of the website. And two, the well-being aspect. We here in Edinburgh are very conscious of that there is a great mental load in this pandemic. And there are tools there that you can use to guide you and maybe even your family members through what is likely to happen as the situation builds up in the coming weeks and months. And there's lots of platitudes around, but the one I do like is that this is indeed a marathon, not a sprint. And we all have much to do to combat this pandemic, but we also need some downtime as well. I would encourage you to look at the well-being parts of this website as well. I'm going to finish there and hand back over to Alistair for some questions. Thank you.
Thanks very much, Gregor. We've had a lot of questions come in. Some are quite generalised and relate to PPE policy in your local area. And I'll probably skip over those ones initially at any rate, and we'll see how we get on. The first questions that came in are whether smokers were at higher risk. And I think that's been shown to be the case in Italy. And probably that's why there are more males who are affected in Italy as well. Yeah. There's a question from one attendee asking about ACE inhibitors, and that's an interesting one, because if we're suggesting that we want to exploit the ACE2 receptors to prevent the virus getting into the cells, perhaps it might be valid to stop the ACE inhibitors. I don't know what you think about that, Gregor.
I think the answer is we don't know for certain, but what we have seen is that in terms of the strong association with ACE inhibitors, we don't know. It's kind of easy when you're critically ill, because they're always going to be stopping your ACE inhibitor anyway. But again, that is going to be a target for research. So it's not a woolly answer there.
Okay. Someone wants to know what the role of steroids is. And we did have a very complicated slide regarding use of glucocorticoids, which we didn't actually put in.
Yeah. So it is very important to say that certainly in China, a large number of therapies were tried, immunoglobulins, very high dose steroids, and we have no good data they work. In our general management of ARDS beyond COVID-19, we have looked at high-dose steroids in the past, and again, there is no good evidence. And we have to remember that these patients are likely to be on a ventilator for a long time. They're going to be very weak, and it may be that steroids will even worsen that weakness. So again, we would use, if they have cardiovascular instability, we would use low dose or relatively low dose steroids to a limit dose of vasopressor. In terms of high doses, there's no good evidence that they work.
There's a few questions regarding actually surgery and what happens in the operating theatre for routine elective surgery. And one attendee asks whether or not routinely every patient should have a CT of thorax rather than a chest X-ray. You have any thoughts on that?
Yes, well, I mean, certainly in the Chinese experience, that is what they did, and they ended up, that was their main diagnostic test, was a CT scan. The latest guidance I've seen from our radiology colleagues in the UK is that they do not recommend that, but there is a characteristic appearance on CT, and certainly we in Edinburgh have seen that reported on our CTs, and sometimes those patients are coming back as positive. But certainly our steer from our radiology colleagues at the moment is you should not be doing CT as a diagnostic tool by itself. I think there is something though that if you are imaging the abdomen and lower chest, you may pick up cases that you need to investigate further.
Okay, one of the questions probably more directed at me is there an increased risk for an orthopedic surgeon due to blood spatter from drilling bones and treating fractures? I think the answer to that is you should be using your personal protection just as we use for all orthopedic patients. There's a couple with respect to intubation. And do surgical patients need longer elective intubation after anaesthesia if COVID-19 is positive?
We do know the answer to that. However, it depends on the phase of illness they have. It depends on the phase of illness they have. If they're at the start, we may be able to get them off the ventilator very relatively quickly. But certainly, even in our own practice, we are seeing patients in the post-operative phase are becoming positive and then getting further respiratory failure. And the course is different from a simple bacterial pneumonia. There is there is a degree of relentlessness to the hypoxia that patients get with COVID. But it kind of is a bit more nuanced than that. We may get them off the ventilator, but they may be going back on in the coming days, if that makes sense.
Okay, one attendee wants to know if CPAP is useful.
No. So all forms of non-invasive ventilation, even though the patients are PEEP responsive, have not been shown to be useful. In our usual practice, beyond COVID-19, non-invasive ventilation, whether it's bi-level CPAP or single-level CPAP, has not been shown to be of benefit. And the great risk there is that it delays your time to intubation. And certainly our initial guidance that we issued at the start of the outbreak here in the UK was that you shouldn't be bagging the patient as you put them off to sleep because of the risk of aerosolization. But the reality is these patients desaturate so quickly, we've found we've just had to do that if we've delayed intubation at any stage.
Okay, there's a couple of questions with respect to how long ventilation should be continued for and how you get the patient off the ventilator.
Yeah, so I think that's very important, and in some ways we are still feeling our way on that, but certainly what we tend to see so far is that the patients over a week or two will very, very slowly get better, and then we can get the patients to breathe by themselves, breathe spontaneously. And then we can make a judgment of whether we could extubate them. If they've been on the ventilator for that long enough, the degree of comorbidity, that may not be likely. And then we would aim to perform a tracheostomy to then slowly wean them off the ventilator. Our worry is that if we have a collapse in our healthcare processes, we simply won't have the staff or the facilities to do that, and then we're a bit stuck.
Okay, resources and the amount of PPE available to the different hospitals, and I don't think we can particularly comment on that. Can asymptomatic carriers transmit the virus?
Yes, they can, very much so. And I think the one thing we do know about transmission is on the PPE situation, Nestle, in that our steer is very much what is in the media, that there are central stocks coming, and that those will be distributed at need areas as soon as they can be. But effective PPE is a concern for everyone, for surgeons and for critical care, and also the emergency department. But this is a pandemic, and it is predictable and understandable that essential kit like that is under great pressure because we all want it across the globe.
Okay, there's quite an interesting question here. There's mounting evidence that COVID-19 affects neurological function. Is this the reason ventilated patients recover so slowly, and might this evidence change their management?
Certainly, we've not seen that in our experience so far, and I've not seen evidence around that, so I kind of have complete ignorance on that. What we have seen is primarily hypoxic respiratory failure, not hypercapnic, which would be more associated with kind of a neurological weakness. But again, I guess there's lots of things we just don't know at this stage.
Okay, I think that's most of them, Gregor, and we should perhaps, due to the time, wrap this up. It just leaves me, on behalf of the members and fellows of the Royal College of Surgeons of Edinburgh, to thank you immensely for delivering this webinar, and also for the attendees for listening in. As a listener, wherever in the world you are, as a surgeon or dentist, remember the college is here to help and support you. Please check out our regular news feeds. In the words of our Prime Minister, we will win the fight against this virus. In these difficult times, please keep yourself safe, and thank you for listening. Good night to you all.